All right, thank you very much. Good morning, Chairman, co-chairmen, and ladies and gentlemen. I would like to bring you to one of the common topics. I think that you might see several of this, during your practice, and I think I'm going to show you some radiographic finding, and then we can go through together of this one. So just want to start from mechanism of the injury. So please imagine that when you got injury to the knee itself, a ligament or the soft tissue that attached to the bone might injure. So that means when the force is overcome, like the stress capacity of the bony attachment, you got tears or some injury of the portion of the bone as well. So this could be either acute injury or chronic injury as well. And maybe, you can observe these incidents more in pediatric cases more than like adult cases is quite common. And when you try to look at your patients, I would recommend you to look at several places around the knee. Especially at the bony prominence of the knee, like for example, like tibial spine, notches, and like plateau or any kind like tubercles, like Gerdy tubercles, medial femur condyle, or etc. As well, patella might be one of the places that could be injured. To be honest, if you would like to do a physical examination, please keep in mind that most of the patient might occur with like hematosis and as well as lipohematosis. That could happen as well. So keep in mind that it is not just only a common of the fracture, maybe just only the ligamentous injury. I would like to say that we can divide these injury into 4 types, which are the first one like the avulsion fracture that involved into the cruciate ligament. The second one, lateral compartment. And the third one, the injury that involved into the medial compartment. And the last one, the injury that involved in the extensor mechanism or retinaculum. I'm going to start from the first one, the cruciate ligaments. This is one of the most common things that you might normally seen, the ACL avulsion. So please have have a close look at the tibial spine, and you might see some of the avulsion as well. You can classify into like several categories as well. But please keep in mind that the mechanism of injury could be like hyperflexion of the knee as well as the tibial rotation. And some of them also occur with the knee hyperextension. And as well, it is also associated with the meniscus injury. So I think that to track back to your practice when you got like injury of the knee, and then maybe some of us might jump to do like MRI scan anyway. So please keep in mind that it would be much better to have like plain radiographs just in case you can see something or spot like this in your practice. The next one, which is also quite common as well, maybe like the second most common, we call like PCL avulsion. So when you look at the back side of the tibia, which is like the posterior tibial eminence, you can see like some avulsion fracture as well. The mechanism of injury could be like sudden hyperextension, and also when you got like violent posterior tibial displacement when you flex the knee like a dashboard injury. This could cause this type of the fracture. Apart from the ligamentous injury, we can shift to the lateral compartment. Second fracture is quite common as well when you see the ACL injury. We have to look at the avulsion part at the tibial insertion of the lateral capsule. The mechanism is quite straightforward, which is intra-rotation with the knee varus, and like I told you from the beginning, that 75% of the injury also associated with the ACL. So like in this picture, you can see like a small chip at the lateral side of the tibial, which is quite close to the capsule. In the past, we normally believe that this is quite related to the ALL, anterolateral ligaments, but nowadays, most of our literature believe that these indicate the insertion of the lateral capsules. So the problem is not just like the ALL only. The next one is the arcuate complex fracture. This injury is located at the tip, the styloid process of the fibula. You've got like several things that attach to over here, for example, LCL, bicep femoris, popliteus muscle, and then tendon, etc. So that means these could bring to the posterolateral corner instability of the knee as well. The radiograph finding could be something like a small chip, like the elliptical bone fragment, just only on top of the styloid process of the fibula. And please keep in mind that these also relate to the ACL and the PCL injury. Apart from this one, there could be several things that could happen at the lateral compartment. For example, IT band avulsion. which is, the place that IT band normally attached to the Gerdy's tubercle. You can see like the chip is going to be a bit bigger when we compare to the C-gon fracture, and the place is not exactly the same. It's kind of like a little bit just inferior, and it could be like near the Gerdy's tubercle. And as well, bicep femoris could be at the fibula as well. It's not like at the tip of the styloid, but it could be a little bit lower to the head of the fibula. And the popliteus tendon, maybe it is not quite easy for us to spot it, but you can take for example, like some spot from MRI as well to see whether you got like injury like this. And the third one, we are going to talk about the medial compartment. One of the most common is the MCL, femoral avulsion. When we look at the femoral side itself, you might see some like a small chip over here at the medial epicondyle. And maybe it is not like acute injury only. When you got like a chronic injury, you can start to have like ossification of MCL, which we call the Pellegrini-Stida disease. So that means it is not like an acute lesion. And please do not confuse with the acute lesion as well. The reverse C-gon fracture is going to be like a mirror image of the C-gon fracture. It happens at the medial side of the knee. It is like the tear of the deep capsular component of MCL that attached to the medial side of the knee. And it also associates with the PCL and medial meniscus. The mechanism of injury could be external rotation with the valgus, which is just the opposite way when we compare to the C-gon fracture. Semimembranosus is going to be another option, but it is quite hard to see. We recommend you to use MRI scan to see it, because this is going to be a little bit lower when we compare to the PCL. This injury involved to the tubercle of the posteromedial tibia and as well at the capsule and the POL. The mechanism is like external rotation, adduction, and the valgus force of the knee. Another, last but not least, the extensor mechanism or retinal column that you might normally see it, especially in the pediatric cases, is the patellar medial avulsion, like MPFL avulsion. In some of the pediatric cases, you can see like a small chip in the medial side that the MPFL attached to the patella. The mechanism of injury is twisting of the movement of the flexed knee and got like external rotation forces that goes to like the patella. And please imagine that when you got like patellar dislocation, not only the ligamentous injury that could happen, you can have like a kissing lesion like contusion and the cartilage itself, especially at the PF joint. So please do not forget to send like a sunrise view to see it as the option of this one. Patella alpha and patella baja could be spot from the normal radiographs as well. When you got like patellar tendon rupture or any kind of quadriceps tendon rupture, it could be spot easily from the lateral radiographs. And as well in the pediatric cases, tibial tubercle avulsion could be happen when the bone is not mature enough. The treatment options, several options could be done. For example, arthroscopic or open surgery. From the left-hand side, this is like the pediatric cases. So I chose to use like headless fixation because I didn't want to interfere like the growth plate like this, like the cross-lock of that one. The cortical fixation could be the options as well, like you can use arthroscopic surgery and then try to drag the ligamentous down to the tunnel and then try to pull it and then tighten it with the cortical fixation. But in my practice, I normally do like pulling and then try to use arthroscopic to help setting up the tension and then try to fix the screw. Please imagine that I normally use like the tension suture as the red arrow here and then try to drag down from the thin nail and then try to place the headless screw like this in this case. Apart from this one, when you see like several fracture as well, like in these cases, this case got like tibial plateau fracture, like on the medial side, and then you can see like a small chips over here at the tip of the fibula. So please do not forget, to fix just only the bone itself, and then try to spot at the ligament as well. Like in this case, I put like a small cancellous screw as well as the anchor suture to be able to hold that fragment down. And like in this case as well, when we try to look at the proximal tibial fracture, we can see that the chip of the lateral is quite big and then quite large. So we try to identify it after we do like tibial fixation. Try to have a look at the PCL itself as well, because normally we can approach it from the back side put like a small cancerous screw to attach on it, try to reapproximate the LCL, and then try to use like anchor suture to be like a figure of 8, like a tension band to hold it back to the place. And this is like the X-ray. And somehow, in some cases, you might not be able to operate. For example, in this case, like 78 years old woman, I mean, she suffered from warfarin overdose. So, I mean, we decided, I mean, okay, we don't want to go for the surgery. So we do like a skillful neglected, like this, we see like avulsion of ACL, and then after 3 years, I mean, it's still over there, but we start to see some arthritis. So you have to keep in mind one thing, that avulsion fracture, I mean, is radiographically stable. However, we have to deal with it. We have to find a way, because right now there is no definite CPG or clinical guideline to mention which one is going to be best option. But I mean, you have to choose by your own based on your evidence and based on your interest. Thank you.